is Betty Tai. I'm the director of the CTN. For those on the East Coast, good afternoon. People on the West, either good morning or good day. Welcome to this webinar. I think you all have seen the introduction of Dr. Gore-Langton's very distinguished, CV. I wouldn't want to wasting time, so I will yield more time for him to talk. But I just want to put in just a few words that in 2010, when the CTN and the CTN were given the charge for developing measures for electronic health records, without knowing anything, we said, this is an exciting project. Once we got the project, the task force started, we don't know what to do. Luckily, we got Dr. Robert Gore-Langton and also from our EMMES coordinating center, also alongside with Dr. Bob Lindblad and Paul Veldhuizen. They really extended their hand helping us. They have done this for many of other NIHICs, and then they guided us step by step. So today, after 5 years, it was just like a wink. And, they led the CTN within NIDA and the CTN at large. Many of our PIs and providers all participated. So this is really a very much of a joint effort. And so I think this is a wonderful time, especially when we had new nodes, new folks joining the CTN. Dr. Gore-Langton's presentation will be very timely. And with all that, thank you, Rob, and please go ahead.
Okay. Well, thank you, Betty. And I'd like to extend thanks also to members of the Center for the CTN, the CTN itself, and the various individuals and organizations that have really collaborated on this work over the last 5 years, without which we wouldn't really have achieved anything. The list of registrants for this webinar shows a broad range of roles and levels of experience in clinical care and research. And for that reason, the presentation will be broadly based, starting with some fundamentals of electronic medical records and then proceeding through to several applications of common data elements, or what we call CDEs. I'm hoping there will be something of interest for everyone. So I'll move to my first slide here. And this is really by way of disclosure of where my interests lie at the bottom. At the top are other perspectives of EHRs. Some of you are probably in these roles. And I'm not going to be covering any of these, as these are not where my experience lies. As a PI in a CRO, my interest is particularly in achieving better research. And then as a consultant for NIDA concerning EMRs and EHRs, it's really to do better SUD research and to support translational activities as well. So where did we begin here? As Betty said, in 2010, this is when I became involved in the project. We started with the realization that data elements for substance use disorders were not generally being included in EHRs. There were certainly exceptions, but there was not a lot of EHR development for substance use disorders. And there was really no process in place to standardize these data elements. There's many vendors and many different things happening, but no standardization. Further, the realization that failure to standardize the data collection will limit its value both in clinical care and in EHR-based clinical research. So that's really where we began. And then on the background of this was the urgency to collect more and better data on substance use disorders. And I'm not going to go through this list, but you will certainly recognize some of these issues. The increase in fatal medication errors, the increased use of opioid prescription drugs, And you know, a few years ago, opioid overdose was a second leading cause of unintentional death, and I just added on to the slide at the bottom there, 2013, that became the leading cause of injury death. So this has been a progressive worsening of situation, but in 2010 we could see this happening and realized that we needed to have better and more data collection in this area. So the objectives for this are really to start off to define some of the differences between EMRs and EHRs. So this is the basic information. Explain the use of common data elements in clinical care and clinical research. And then briefly I'll outline what I think is a role for CDEs for substance use disorders in an integrated vision for clinical care and clinical research. Okay, so a brief history of clinical information systems. Unless your experience in this area goes back 20 or 30 years, you won't know about this, but computers were starting to be used in the 1950s, and basically they launched in hospital systems of various sorts. And then in 1991, so 25 years ago, the Institute of Medicine had a landmark report in which is entitled here, The Computer-Based Patient Record, an Essential Technology for Health Care. And in that, they defined a computer-based patient record, or CPR. And I'll read this because it's important, I think, to note. The electronic patient record that resides in a system designed to support users through availability of complete and accurate data, practitioner reminders and alerts, clinical decision support systems, and links to bodies of medical knowledge and other aids. And the underlining is mine, some of the things that I thought were particularly important, the availability of data, completeness of the data, and some actionable things that can be done. And this was really their concept. And out of that grew the ambulatory medical record, sometimes called the electronic medical record of EMR, and subsequently the electronic health record, or EHR. And sometimes we use these two terms, EMR and EHR, interchangeably, but they really are quite distinct. I'll make that point going forward. There's also the individual or personal health record that virtualizes a patient's complete information, providing more access to it from the patient. These have limited implementation, and I won't talk more about that, but in the future that will be more important. But we'll consider mainly the EHR today. So what are the differences between an EHR and an EMR? Well, we started off with this concept, and that was just a concept of unique coding of searchable data items. And then the EMR, or electronic patient record, EPR, developed. And really that only requires that the data be in electronic form. It doesn't have any other specific definitional requirements, although clearly most implementations have other features. And then the IOM in 2003 came up with these key capabilities for EHR systems. And you can see what they are on this list here. There has to be longitudinal data collection of the record. There needs to be immediate access, so it can be used immediately. There needs to be knowledge and some decision support. And I'll have to interject to apologize here, but we're near a fire station, so you're going to hear some sirens going. I apologize for that. So the knowledge and decision support, and then to share the patient's complete health records. And that's the ideal. Very seldom does any electronic record have everything that the patient has done, all the encounters they have had, but that's the ideal. And then also it added on to this the efficiency for healthcare delivery. So I just want to emphasize a couple of these points. So one of the points here is that the EHR is really a consolidation of encounters. So you could have encounters with different doctors in different hospitals. And the EHR will really be a consolidated record rather than an individual institutional type record. And that record then may have a personal health record associated with it. And these electronic health records are generally regional, or they may be institutional networks. And eventually, the hope is that these larger networks will eventually merge into a nationwide health information network, and that's a term that is federally used as a direction we're heading towards. Another important point, of course, is that as the patient is seen in different settings over a period of time, all of these records will remain in the electronic health record between different geographic settings and over time. And this is important to the effective use of the electronic health record. So quite distinct from EMRs that don't have these types of features. So some of the anticipated benefits of health information technology, often called HIT, and electronic health records are shown here. So for the patient, obviously better quality care, reducing medical errors, perhaps reduced testing. If you have to go to an emergency care, your records are there so you get the proper treatment. And then more accessible and better transparency of the records. Some would also say that you have better privacy and security with electronic health records, although I appreciate that that's a very contentious issue, and for this to be true, it really depends on a very effective implementation of the electronic health record. Then on a more broad scale, population, country, state-wise, more efficient processing, hoping to save millions, monitoring of public health, acceleration of clinical research according to the Institute of Medicine's idea for a continuously learning healthcare system. Now some of these values have been documented. There's lots of online sources of these. I've just picked one here that show the types of numbers for increases or improvements in satisfaction, both patient and staff, improvements in clinical treatment through lower readmissions, longer physician time spent with patients, reduced claim denials, better education and patient compliance, and then at the bottom some of the numbers that have been bandied around about savings. If you look at the many different sites, you'll see all different numbers for these, but this is the kind of thing that we're seeing for potential benefits of electronic health records. This shows a graph of the adoption of this. Now there are graphs like this for hospitals. I'm just going to show them for physician, office-based physicians. And you can see there's been a steady increase over the last 10 years or so in EHR systems. The one that says any EHR system means just that, basically any EHR, no specific requirements. And you can see in 2013 about 80%. And then the basic system, this is a term that's used. It's a little bit misleading because basic you'd think is simpler, but it's really one with advanced capabilities, and that's why the adoption rate is lower for that. But you can see there has been a steady increase in the use of EHRs. And then this figure shows, you can see the number is different here. For America, 93% adoption. And you can show compared to other countries that we seem to be doing fairly well, with Germany at about the same level. These are 2013 figures. And I believe it's Spain being a little bit better. So there is wide use now of electronic health records. In fact, it's pretty hard to see that you could go anywhere for medical care and not be involved with an electronic health record of some sort. There are some barriers to the EHR implementation. They're listed here. High implementation costs. It's not always clear who's going to benefit. I think physician providers think that they're paying for the implementation and the payers are getting most of the benefits. And so these are issues that aren't entirely clear. There's also liability issues, HIPAA 42 CFR Part 2 for concerning implementation in EHRs. Other limitations are choosing the appropriate software, and once you do that, there's sort of vendor lock-in. It's not easy to switch. And then there's usability training, potentially high failure rates in doing this. All have been barriers. Some of the offsets have mainly been financial through the Centers for Medicare and Medicaid Meaningful Use Incentives program under the HITECH Act, and then other types of funding for integration and training and support. Federal leadership has been major in this area, and I couldn't list all the things that are involved, but the Office of the National Coordinator for Health Information Technology created an EHR strategic plan, and out of that they developed this nationwide health information network, which is really a set of specifications, and subsequently a nationwide health information exchange, which is a public-private partnership data exchange, which really serves as a demonstration type program for the use of these systems. There's other leadership that can help with implementation. Some public domain software, for example, VA software is freely available. There's certification programs, and then there's the CMS Meaningful Use program that I'm sure you've all heard of. So this slide shows the 3 stages of that program beginning in 2011, emphasizing data capture and sharing at that point. Stage 2, adding advanced clinical processes, and in Stage 3, which is in 2016, focusing on improved outcomes. So what makes an EHR meaningful? This then provides some of the criteria that have been provided for each of these stages. And I'm not going to go through all of these in detail, but when we began with our interest in this, Stage 1, which is starting, and I put an arrow here besides standardized format. So this is one of the things we focused on, how to standardize the format for data collection, leading to common data elements. And through Stage 2, there's other things we weren't involved in, but you can see things being added like e-prescribing, patient care summaries, and so forth. And then in Stage 3, the focus is really on improved health outcomes, but adding decision support. So this is another area with an arrow showing something that we're interested in. And some of the other aspects below that, self-management tools, more comprehensive access to patient data, and improved population health. So these are all the things that are being used to define meaningful for electronic health records. Okay, so what and why common data elements or CDEs? Well, a common data element is, as you might gather from the title, a shared data element. It has some common features. There really is no standard for common data elements. They are widely used. The term is widely used, but often meaning quite different things. It basically means that some standard has been developed and it's used widely enough that we can call it a common data element. So that's still the current situation today. For our purposes with the NIDA development, we've focused on using a fairly rigorous standard, the ISO 11179 Metadata Registry International Standard. This is a standard used also by the National Cancer Institute and implemented in their curation tool for CDEs called the Cancer Data Standards Repository, or CADSR. And we have used that repository to create CDEs for NIDA, and in part because the company that I'm in has developed and maintained the repository of all of NCI's large collection of data elements using this tool. So we had a lot of experience in this area and decided to leverage that in developing data elements for NIDA. Now, some people ask, well, what do you really mean by a data element? What does it consist of? I mean, it does consist of a data element, a question, some valid values and so forth, and you could have that without having a common data element. The common data element is created by all the metadata associated with it. Often you start with a controlled vocabulary, and from that then you develop the structure, value, domain, the concept, and so forth. And it's in the metadata that you assure the standardization of meaning and use of this data element. I might just mention that for most of the data elements we're creating for NIDA, we don't really use a controlled vocabulary, and that's because we've relied more on validated, published data instruments. And so it's a controlled in a sense, but not the usual sense of a controlled vocabulary. Okay, so the CDEs, they provide the standards for interoperability, and the principal standard is a semantic one. It's really to establish the meaning of the data so that when it's used in one system or another in exchange, that meaning is consistent across systems. So that's a critical point, I think, for any kind of data element, particularly important, I think, in the area of behavioral health, where the meaning and wording of the instruments is quite crucial to the kind of response and the data you obtain, but true for really any data element. In addition to that level of interoperability, there's syntactic or technical, so the electronic formats, things that you've heard of like HL7, et cetera, et cetera. There's many different standards, and those standards are still evolving. And the Office of the National Coordinator for HIT is really one of the leaders in developing those kind of standards. You also need, of course, some standards in business processes, but that we won't get into any of that. Okay, so when collecting data, there's this, well, you can see the title there, Collect Once, Use Many Times. So this is really a holy grail, I think, of reuse of data, and try to minimize creating data elements over and over again, but try to come up with some core set that can be reused, and that's one of the aspects of common data elements. And there's obviously a core set that overlaps here, so there may be data elements that can be used in clinical care and clinical research and some of these other areas. And in creating data elements for electronic health records, our hope is to first build on that core, things that can be used in clinical care but can also be used in research, and they can be used over and over again, providing high efficiency in clinical research. Where does the data come from? It comes from many sources, databases and notes for clinical research, clinical trials in electronic data capture, EDC systems, and health care, of course, in the records we've been talking about. The problem is integrating that data across multiple systems and standards. I've done some of that in the past, and I can tell you without common data elements, it can be a very trying business to map all these types of data. So what we have tried to do is achieve an efficient means of data collection, and some of the general objectives of common data elements are listed here, and these I've taken simply from the NCI's site. So their objectives really are the same kind of objectives that we have. Overall is to harmonize, standardize, and simplify data collection. And then you can see some of the objectives they have: discrete defined items, consistent data collection, reduce redundancy, consistent reporting analysis, reduce error by not having to translate data, there's no data mapping required, and of course sharing the data through interoperability. If we can add to that some clinical and research objectives, specifically I guess for SUDs, or perhaps applicable to many areas of research. This includes standardizing data for clinical trials, registries, the EHRs we've talked about, clinical decision support, quality measures, And then we think they'll also be very useful in integrating substance use disorders into clinical research and with data collection in general medical care as well. Interoperability, of course, is required in all of these initiatives. So CDEs are now widely used at the NIH, and there is this website that's maintained by the National Library of Medicine. If you go on there, you can find the different subject areas and see what CDEs are available. And I'll just take you to a page of that. And if you look down the left side, you can see the different initiatives. If you look down the subject area column, you can see the different types of disorders that are covered: asthma, chronic low back pain, so some are quite specific, cancer, ophthalmology, rare diseases, etc. And down here with the arrow is the NIDA group of common data elements. If you look at the numbers of elements, you'll see they vary quite a lot. So the NINS project has about 10,000, and you can see that the phenotypes and exposures one has many variables. And so this varies quite a bit across the different groups. So the NIDA listing currently has somewhere in excess of 80 common data elements. So we're quite a small player in this at the moment. So just to say something about the process of developing these common data elements. Some groups might use a more formalized, like a RAND Corporation Delphi type process. We've chosen to use expert consultation and consensus, and to have some iterative aspects to that, sort of like a Delphi process, but a little less formalized. And this has involved workshops and symposiums and meetings with various involved groups. Shown on this slide here, our target, you can see there, was to develop common data elements for SUD, EHR, and I thought when we were starting off it was good to give something that would direct us towards a common target. But you can see all the lists of the organizations that have been involved. There's federal, state organizations, professional organizations, and early on we had a lot of help and feedback from community treatment providers and healthcare providers as well. And all of these consultations fed into the development of common data elements for NIDA's SUDs. Some of the key workshops, one was started off in 2010, and we sort of formulated a plan at that point. And then there's been others. There was one in 2011 that run by NIH and the Society for Behavioral Medicine that was broadly based, and various other professional venues where we held workshops and symposia to get feedback from the providers, particularly primary care providers. And out of all of these consultations came a number of key recommendations, and I've just put some of the major ones up here. So we were, along the way, decided we were going to focus primarily on primary care and electronic health record, because that seemed to be where we get the most bang for the buck, in a sense. And so in the consultations, one of the things that came back was keep it brief. So I'm sure you all have heard that before. Primary care, you don't have time to work through a lot of complicated data elements. So keep it brief was one. Combining tobacco, alcohol, and substance abuse was also recommended, although it became difficult because of the next one, which is the use of validated screening questions. It was hard to find validated questions that had all of these things validated within the correct populations, the primary care populations. I think now there's one on near to be published that may address this issue. So these issues are being resolved as we work on this. Important to develop the longitudinal questions that we've already mentioned. and where there's no validated questions, use of standardized questions or instruments, and then to incorporate clinical decisions and evidence-based interventions so that there's some actionable items within the collections. And also to consider the ASAM dimensions and Joint Commission standards, which we have done in developing these data elements. We have obtained feedback, particularly from primary care providers, that added a little more granularity to this perhaps, and the need for a single question screener, and that is something that we have implemented as a common data element. Brief assessments, 3 questions being better than 10. And one comment that I focused on, perhaps I shouldn't have, but one comment we got was, well, you know, it really matters more that you get on with it and start making these data elements available, and it does the exact question you implement. Perhaps not quite true, but it really focused us on moving forward as quickly as we could. And then for EHR development, making sure that the questions and assessments are validated. And this became particularly important when we moved on to doing clinical quality measures. So I'm not going to go through all the common data elements that we've developed, but I'm going to just give you an introduction to where these are. So we created a common data elements website here, and you can see the URL for that there. This website draws on data that's been curated in the NCI's Cancer Data Standards repository, so we don't duplicate any effort. It's all done in that repository, and then it's pulled from that site to display on this website. And the purpose of doing that is that the CADSR is a rather complex tool, really designed for developers more than for end users. And this pulls up all the relevant data elements so they can be easily seen, and then provides further information on how to use the website. So there's a welcome page, and then there's a separate descriptions for clinical investigators and vendors. So we really want to promote the use of these both in research and clinical care, but also to get the vendors to buy in to implementing these, which is obviously a difficult challenge, but one we're hoping to embrace more in the future. This is just to show one of the pages here. So if you click on the instruments link at the top, you now get a link of all of the instruments that are available. That's more than is shown on this page. I'll just amplify that a bit. And I'm sure you'll see things that you recognize here. So these are all mainly validated published instruments, which has been our focus. And in addition to the ones shown here, we also include the demographics and the substance abuse and addiction data elements from the Phenotypes and Exposures website. And they have been assisting in developing common data elements for use on our site. So that greatly expands the number of data elements that are readily available to users of this site. So these are all data elements that are being recommended by NIDA for use. And there are 2 tabs. There's one for clinical research, and there's the one clicked here for electronic health records. And so we've tried to separate out things according to what we thought they would be most readily used for. Just to drill in on one of the data elements, so you can see this is a single question screener for drugs, and it allows you to drill down to other types of information, and you can actually eventually get all the information that's in the metadata on the Cancer Data Standards repository, although most people would not need to go to that degree. So I'm not going to say any more about the specific data elements we've developed, but just to indicate that we will be moving forward in the future to develop more data elements, more broadly based than simply a small core for the electronic health records. And we expect that that will occur in a number of areas that we've already identified that you can see around the outside of this. And you can see that these basically represent this wheel of the ASAM dimensions. So we hope to have recommended data elements in all of these areas eventually. Okay, data elements have also been used for clinical decision support, or created for that. And I just want to mention that there was an initiative started by Geetha Subramanian, who held this meeting in 2011 to look at clinical decision support for screening and brief intervention. And there were feedback sessions at INEBRIA and the CPDD meetings. And that resulted in an algorithm for clinical decision support, really our first attempt at this for screening, brief assessment, some sort of plan of action. And you can see this is just a picture off of our poster actually. You can see that we incorporated a single item screener as a CDE, the DAS-10 as a CDE, and additional questions that we were also created as CDEs. And then based on the scoring, came up with levels of risk, minimal, low intensity, high intensity, and with plans of actions associated with those. And so this is all created and available on the CD website as common data elements. I'll just go and take a look at the high intensity page so you can see what was on one of these pages. So there were screening criteria, and depending on the DAS scores and some additional questions that might be applied, the high intensity intervention, or the red level, would be selected, and then there would be various actions to consider that you can see down here. I might just mention that at the time, a separate little bit was added at the bottom for patients with opioid dependence, and I might just mention that there's a study underway now to develop an algorithm for opioid use disorders, led by Andy Saxon and Gavin Bart, and we expect that when that is fully developed, some of the data collection elements for that will be created as CDEs as well. Another area in which common data elements has been used is in creating an electronic clinical quality measure. And so there was a recommendation from an ONC SAMHSA Behavioral Health Technical Expert Panel in 2012. You can see it's for screening and brief intervention for tobacco use, healthy alcohol use, non-medical prescription drug use, and illicit drug use. And this recommendation was implemented as a quality measure. It has been largely specified now electronically, and it's available as in the pilot program of the National Quality Forum. It still needs further scientific validation evidence for use before it's widely used, and that is, we recognize, a challenge, and a challenge we're not sure whether we're going to be able to achieve or not, but we've been working towards that. And this is another area then where the use of common data elements is important. I want to just turn the last few slides to talk about integration under the Affordable Care Act and other legislation that's focused on this. So what do we mean by integration? The definition is provided here: whole person care that focuses on overall health, creates partnerships across all aspects of health, and is facilitated by a variety of clinical, structural, and financial arrangements, community supports that remove barriers between physical and behavioral health care. So what role do EHRs and CDEs have in that? Well, the EHRs, of course, cross boundaries of individual organizations. And so I think it's very important in this type of integration to have the EHRs available. And I think more broad use of EHRs across boundaries is going to be very important in this respect. And further within this integrated clinical care environment, there's going to be further integration of clinical care with clinical research, and that will then foster this IOM vision of a continuously learning healthcare system. And within these activities, the CDs then will provide the semantic interoperability that's important for meaningful data in clinical research. So I'm going to just leave you with this one last complicated slide. And for this, I'll just bring up my little pointer here. This was sort of developed as a mind map a couple of years ago to sort of see where we should be focusing our area. And you can see that at the center of this is the integration of substance use disorders into primary care, led by things like the patient-centered medical health and chronic care model, etc. And this integration of SUD into primary care is being supported by technical standards and by law, policy, regulations, methodology up here. And the aspects that NIDA has been involved in, obviously supporting translational research for clinical care data, including the use of electronic health records and clinical decision support. All the things in red are really the areas that we were interested in focusing on at the time. Developing the website for CDEs with the purpose of supporting CTN investigators or anyone who really wants to use it in performing research, but also providing sources for the EHR vendors so that they can now start incorporating these common data elements into the standards that will be used in integrated care. Then the other side of things is, of course, the clinical data research that's providing data to improve clinical care and the data that derives out of clinical care to support the clinical data, the clinical research, things like randomized trials, registries, comparative effectiveness research, etc. So this is probably not too out of date at showing the things we started to try to achieve. So I think at this point, turn my pointer off here if I can, just to indicate there's a few selected references at the end on EHRs, and these were chosen primarily because if you search them in Google, you can find them easily. And then beyond that, we have a few references on the development of the CDs that are in the published literature, so feel free to look at that. At this point, Tracy, I'll turn it back to you for a question period. Okay, so I'm seeing one question on the chat thing here. Dan, what about the new promised short form dimensions on alcohol and substance severity consequences? Well, these may be things that we do need to develop, and I have to say I'm not familiar with that. Mostly our promise elements were being developed based on advice we've received from others, and this is probably one we need to look into, but I'm sure there will be a growing list. What will the process be for adding the metrics like those, Dan is asking. If we have a recommended data element, we can certainly add this as a common data element. When you say the metrics, I'd have to probably look at the data element to see what's required for that, unless you have another question about that.
We had one question another question in the chat from Lisa Chen, and that is for EHR and fitting in the 42 CFR Part 2 into the health records. Is there any information about that?
Well, there isn't information related to the things I've been working on. There is a data science group at at NIDA that is looking into various issues related to 42 CFR Part 2, and I'm sure these will be issues that will be considered, but I don't have any information on that at this time.
Great. And Jennifer McNeely has a question. Go ahead and ask your question, Jennifer.
Hi, thanks, and thanks, Rob, for that's a great, really comprehensive presentation. Thank you. I had sort of a two-part question. One is, as new instruments become available for collecting substance use data, how will you evaluate them and decide which should be included as CDEs? And sort of the follow-up to that, if we're now convincing EHR vendors to use the CDEs that exist, would new screening tools then replace or simply become another option? Because I think the vendors will probably be reluctant to pull stuff out of their EHRs that's already built.
Well, to answer the last first, I think they will be in addition to what's there. So, I mean, the users of the website will have to make their decisions on whether they want to upgrade to something new that's been added or continue to use something that's already there. I think if we get to a point where there's any data elements on there that we think should not continue to be recommended, then we would probably take some action on that. But I don't see that as something that's going to happen in the near future. As for adding new common data elements, as we began this process, we had a lot of workshops and symposiums and so forth that led to the recommendations. Now that is tapered off substantially now at this point. We don't have a similar process in place, but I think what we'd be looking for is recommendations from any end users for data elements that could then be considered more widely. I can't say that there's specific criteria that you could check off to see whether something would qualify or not, but something that's validated, has published validation, that's still a strong requirement, I think, for including in recommendations for use in EHRs. As we develop data elements for more broad use, then that standard will not be required. So it really depends, how this is being recommended. But so I mean, I think to answer probably your question about things I know you're developing, if you recommend them, we'll consider them. And that's true for anybody else who's on the line as well.
That makes sense. Thanks.
Okay.
Thanks, Jennifer and Rob. Any other questions?
This is Kathy Bradley. Great presentation, Robert. Thank you so much.
Hi, Kathy. Thanks.
My question related to what you know. I don't know of any, but I thought you might know of any validation studies of the NIDA common data element for drug screening or other assessments for drugs that has been validated when it's in an electronic medical record, so not when it's confidential and the patient knows nobody will ever see it but the researchers, but when they know their provider and potentially people they don't even know will see it in the EHR. Do you know of any work in that area?
Well, I don't really. I'd have to go back. I mean, I'm not sure. Some of them might have been validated using electronic health records, but I'm not positive about that. If there's anybody else on the line that feels they have an answer to that, please pipe in.
Thanks so much.
Hi, it's Jennifer. I'm pretty sure none of the common data elements have been validated, incorporated in an EHR.
Thanks, Jennifer.
Right.
Appreciate it.
Okay.
Great. Anyone else? If you could use your virtual raise hand button, I'd love to have you participate in this discussion too. Dr. Ty, did you have any other words to share with us?
Thank you. I think I want to address a question just raised a while ago, EHR and 42 CFR Part 2. I think, those are separate issues, I think, 42 CFR Part 2 is more on the exchange of information. The EHR is something that, basically you collect patient data, whether it's on substance. But I think the more of the 42 CFR is when you exchange that information. So I don't quite catch, what that question is about, but my understanding is that 42 CFR does not prohibit you with taking the patient information. It's just whether you can share that or share with whom is the consideration. I hope I am correct in that. Thank you.
Hi, this is Lisa Chin. I'm the one that posed the question about the health record.
Okay, sure.
So my understanding of 42 CFR, if the electronic records are accessible by providers, various providers in the community, regardless of agencies, then how does the 42 CFR Part 2 fit into the confidentiality piece and helping others understand the restrictions under the substance use and sharing of that information? For healthcare, we understand patients need to have providers understand know their information. However, most providers don't know that they can't share that information with with other people, or restricting records for whatever reason. Records need to be released to other places. So in the place that I work, one of the challenges is putting my records on our database. Because I'm a substance and mental health counselor here, that the only people that have access to my records is at this point is a select handful of people.
Okay.
Because of the 42 CFR Part 2.
Yeah, that is a statement that we certainly perhaps can address in another time.
Okay.
But I think I saw Dr. Dennis McCarty is on the call. Dennis, are you still there? Okay. My understanding is that the 42 CFR applies differently to research and to patient care. I think, in our remaining 1 minute, we probably won't be able to have a meaningful discussion. If you can send me an email, I can send you information.
Okay.
For that, because I just came back from a MRSA meeting. There was a debate between Dr. Wesley Clark and Dr. Keith Humphrey. It was a very interesting, very spirited debate, but both of them have addressed this issue in the past. I certainly can refer you some references you can take a look. Thank you.
And just so that you all know, we have been considering this very topic for a future webinar here with the CTN, and we'll talk more with NIDA about bringing that topic to this audience.
Yeah, that'd be wonderful, because we keep on waiting for the SAMHSA to issue the new version, and it's been months. I don't know what's holding it up. So.
Can I have the email address, please?
Oh, sure. btai, B as in Betty, btai at nih.gov.
nih.gov.
Yes.
But I had one more question before we close. Kelly Duran, please ask your question.
Hi, this is actually Ryan McCormick sitting with Kelly Duran. But,
okay.
I noticed that the audit and the audit C are listed, and I apologize, I missed the beginning of the talk, so I hope this wasn't addressed. But I was wondering if you are including the single item alcohol question in this as well, or considering that?
Yes, I think that is considered. Yeah, that is in there. It's not on the. I don't think it's on the slides, but
yeah. And then I'm also wondering if the follow-up for the positive for that for further assessment is if the recommendation is the full audit or something else.
Well, yes. I mean, the full audit is available. It probably is longer than would be used in most situations that we're recommending, but it's available. Yes.
Yeah. I guess the question or the problem we're running into is that I'm setting up a program in the emergency department, and a single item question is more feasible there, but wondering what the next step after that is for further assessment.
Well, that is an area that I'm not an expert in, further assessment in the alcohol area. So, I mean, if somebody else would like to give a response to that, I'd be quite happy.
And the alternative, if there is someone on the call, can you send an email to ctntraining@ms.com, and I'll get this information over to Kelly Duran and her colleague, and then we can pick this discussion up at another time. Is that okay?
Yep. Yes, and I'll register so you have my information. It's Ryan McCormick.
Okay.
Okay.
Sounds great. Thank you all so much. This has been a great topic. Rob, love this topic. Very, very comprehensive coverage. Thank you. Dr. Tai, did you have any closing words?
Oh, I just want to thank everybody for getting on the call, and especially on the Veterans Day. I know many of you are off, and participate in this means a lot to us, and we will continue this series, and please stay tuned.
Thank you. And we will post this recording on the CTN Dissemination Library's website when we've edited a bit. And that will end our presentation. See you all in 2016, and we'll be reaching out to you with the program once it's scheduled. Thank you.
Thank you all for attending. Bye.